All right, so this morning, I would like to introduce you to a panel to discuss foundations of business and institutional COVID-19 vaccine policy. What we're hoping to touch on is precedents for current and prior United States vaccine requirements, the pros and cons of vaccine mandates for disease transmission, and we'll talk about K through 12, college and university settings. We'll have some special perspective on the decisions made by a local healthcare organization here, and also the importance of viewpoints for other businesses. We'll talk about it from the perspectives of epidemiology, public health, and legal considerations. The more proper name is SARS-CoV-2, but I'll keep saying COVID-19 because that's what's in the press. The other place I'll depart from usual professional presentations is by using brand names for vaccines, because I think it'll be quicker and more easily understandable than trying to do otherwise. We are going to talk about policy making at the population level. We're going to save some time for discussion. And when we do discussion, if you're live in the room, please use the mic so that we can all hear you. What we're not doing today is setting policy for Rotary or anywhere else. We're not offering official medical treatment or legal advice. We're not debating the medical aspects of the vaccine, and we're not challenging anyone's personal viewpoints or religious beliefs. This is intended to be informational and respectful, and I'm really looking forward to a great discussion. We are purposely coming at this not from bias, but from useful perspectives based on the experience of the speakers and the author of a paper that I sent out, Lawrence Gostin. So who are these speakers? We have Dr. Jeffrey Feit, MD, MS, and he is currently Valley Health Population and Community Health Officer. He is board certified in family practice, has practiced as a trusted voice in Fairfax and Luray. He was a graduate. He did graduate from UVA School of Medicine and did his residency at UVA as well, which of course puts him in high esteem in my view to start with. And he's a former vice president of medical affairs at Page Memorial Hospital. And he's worked very hard and been a tremendous guiding light to many of us in the medical and other professional community as we try to roll with the punches during the last year and a half. And we are honored to have Robert Light, JD, who is well known to us as a member of Rotary and has talked to us before. He's in legal practice with Joseph Silik. His area of concentration is corporate and commercial law, labor and employment law, real estate and land use planning. He received his degree from Washington Lee School of Law and is a former president of the Warren County Bar Association, as well as clerking with the United States Department of Labor Office of Administrative Law Judges. So what are some of the historical roots for vaccine requirements publicly expressed? A very old concept is the harm principle, that there is a freedom of action for competent adults unless it poses a risk for others. And this was perhaps most eloquently discussed by foremost philosopher of the 19th century, John Stuart Mill, in Britain. And the US Constitution states retain theoretically the reserve powers possessed as sovereign governments before the Constitution was ratified. There's a lot of push and pull on this. It gives the states the so-called police power to regulate private interests for public good, particularly to protect the public's health. And the Supreme Court has upheld this many, many, many times over the years. Congress can pass laws that theoretically they have the powers to tax and spend, to regulate interstate commerce. That's where occupational health arises from, to negotiate treaties. That's where our quarantine and country entry and tuberculosis rules come in, and protect intellectual property, et cetera. Theoretically, Congress can pass laws that allow federal preemption of some of the states' rights and provide a floor or ceiling of protection. So here's a case that started it all. Jacobson versus the state of Massachusetts. It set a national precedent for lots of public health actions, and in particular for vaccine requirements. It brought forth the idea of a social compact, that the whole people covenants with each citizen and each citizen with the whole people, that all should be governed by certain laws for the common good. It did not permit forcible vaccination. It was the case of a minister and his son who declined to receive vaccine, and ended up losing and being fined. And again, this case allows penalties, fines, or restraints. You'll see those expressed as quarantine, denied school admission, fines, things like that. It also confirmed that the lack of a health exception is unconstitutional, but belief against vaccine is not an excuse, and it does not depend on vaccine efficacy. So that was very explicit. This ruling attempted to create a reasonable balance between individual and community interests, and we don't have time today to talk about some of the things that it's been used for. So that brings us fast forward to the Viewpoint 2-page opinion piece by Lawrence Gostin. He is the grandpa of public health law and keeps writing to this day. Anyone who gets a master's in public health will be reading his books. So here's what this Viewpoint takes a look at. What are the considerations for mandatory COVID-19 vaccines in K through 12 schools, at the college and university level, and in businesses? So we're going to take a look at this from the epidemiologic, law, and public health viewpoint at each level. So K through 12 schools, what's the situation? COVID-19 is usually asymptomatic or mild, but there's a risk of a prolonged syndrome and death. Pediatric infections are increasing. It's 24% of new cases. It's going to be impossible to get adequate herd immunity without vaccinating pediatric patients. There's 3.9 million cases with more than 16,000 hospitalizations and more than 320 deaths. These are numbers as of May of this year. The Pfizer vaccine is 100% effective in a study of several thousand in the 12 to 15-year-old group in preventing symptomatic disease, and it reduced transmission. I've put links for you if you want to read more about this. What about law? Every state requires childhood vaccines for school entry. Many grant religious exemptions. That's 44 states, including Virginia. 15 states grant philosophical exemptions. 6 states have medical only. Public health. We got behind the 8 ball because pregnant women and children were not included in the initial studies. So we're playing catch up there and looking at live experience. It's really too soon to understand what the post-market surveillance will look like, the long-term safety. We do hope that 12 to 15-year-olds will be vaccinated. But in terms of compulsion, we recommend trying incentives first. We need to build public support. We need to avoid backlash from a premature mandate. And incentives haven't worked that well for adults, but perhaps we can do a better job here with kids. What about the college and university viewpoint? Well, unfortunately, there was a natural experiment because the higher education facilities that were open for the 2020-2021 period had much, much higher spread. There were more than 660,000 cases, 100 deaths or more. The Pfizer vaccine was 95% effective in 16 to 25-year-olds to prevent symptomatic disease and reduce transmission. What does the law look like? Well, actually, institutes of higher education have a pretty broad ability to make their own policies. Internal policy usually at this time requires on-campus and fraternity student vaccine for a great variety of dangerous contagious diseases. And in the Journal of Higher Education in Virginia, all of the schools reported in requiring student vaccines, most required employee vaccines as well. And just this week on Monday, a federal court upheld Indiana University's COVID-19 vaccine mandate. And EEOC guidance shows that they believe the vaccine requirements to be lawful even while it's under experimental use. And that is the Equal Employment Opportunity Commission. Public health vaccine requirements are recommended, but the one trick in the university system is the large number of foreign students. So which non-US vaccines are going to be acceptable is still under consideration. The World Health Organization is making lists to help us with that. Each university has to set up its own safety protocols for those with medical or religious exemptions. And state laws are popping up constantly and some of them contradict the national recommendations. So universities have to obey state laws, and you have to make this doable. It's strongly recommended that no-cost vaccines are easily available to everybody. How about the business viewpoint? Well, some state restrictions apply only to state employees, and I'll talk about that in a second. From the epidemiologic point of view, the super spreader events are highly linked to bars, restaurants, churches, athletic events, and only 41% of the population is fully vaccinated. We clearly have effective vaccines available, with greater than 90% for the mRNA vaccines, Pfizer and Moderna, and greater than 80% for Johnson & Johnson. And now we're seeing this to be demonstrated true in actual use, as opposed to just the studies submitted by the manufacturers. What about the law? Occupational safety requirements, OSHA, requires the provision of a safe and healthy workplace. The EEOC guidelines permit requirement of COVID vaccine as a condition of employment. And asking about vaccine status from employees is not a HIPAA violation, contrary to popular rumor, and it does not commit other privacy violations. However, remember, state law trumps the EEOC. In at least 11 states, there are laws or executive orders right now restricting COVID-19 vaccine mandates or proof of vaccine requirements. So we need to keep an eye on that. It's tricky to know what's going on in your state. And I'll look forward to hearing what Robert has to say. Private companies otherwise have pretty wide discretion if they demonstrate no discrimination based on race, sex, disability, or other legally protected status. Remember, no shirt, no shoes, no service. Well, you can do that with masks and with other things too. What about the public health? Well, we hope not to use mandates, but that is likely to be very effective if high coverage is not otherwise achieved. And again, mandates and vaccination proof are likely to enhance coverage. equitably if doses are easily available without financial and other barriers. We talked a little bit about having strict protocols for the unvaccinated in businesses, which will protect people and also make it more attractive not to have to jump through all those hoops. So now I'm going to hand it over to Dr. Jeffrey Fight for Healthcare System Perspective. I will advance the slides for him.
Thanks, Deanne. Thank you all for allowing me to spend a few minutes with you today. I have my only connection to Rotary right now is I'm very proud. My older daughter, Leah, is the incoming president of Interact at Hanley. And I'm always amazed to see the amount of work that the Interact Club and the Rotary Club up here in Winchester do. So I appreciate all that you all do for the community. So I am not a lawyer, and I will not try to play one on TV today. We have had an interesting journey around this vaccine, both from the perspective of, you can go to the first slide, Sam, thank you. When the vaccine first came out, we were so excited to start to give it. We have this very unusual situation as a health system where we overlap geographically really fully with the Lord Fairfax Health District. We share the exact same geography. And we're the only health system in that district, more or less. And so while where other health systems sort of vaccinated their own employees and said, okay, we've done our thing, Valley Health took a very different tack and said, hey, we are responsible for the community's health, and we really want to be involved in the delivery of vaccine. And I'm really proud. We've delivered over 150,000 vaccines in this community since the beginning of the year, in partnership with a lot of amazing partners. Everybody from the National Guard coming in to help us, to amazing thousands of volunteers coming into the clinics to give shots, and of course the large mass site we set up at Shenandoah University here in Winchester, which did 80,000 shots and received a lot of really positive attention, both locally and regionally. So the vaccine has been a part of our life now for 6 or 7 months, and I'm really privileged to come talk to you about it. So first, I want to ground you on, and I know Cian mentioned this earlier, COVID's a bad disease. And I think it's easy to forget that. It's easy to drop back into that mindset of, hey, this is the flu, it's another bug, it'll go away. I wrote here in 2020, COVID was the third leading cause of death in America. But if you take the COVID fiscal year, which is sort of April 1st, 2020 to March 31st of 2021, COVID killed over 600,000 people, which would have made it the second leading cause of death in America. And that's if you go by what's written on the death certificate. But probably the more impressive academic work that's been done about this uses a different technique called excess deaths. And what excess deaths is a way of looking at cause of death that asks the question more broadly, which says, hey, in an average year, how many people would have died and how many people died last year? And if you look at excess deaths last year, the number from COVID is probably closer to 800,000, which would have made it the #1 leading cause of death in America over that 12-month period. So this is a terrible disease, and I don't know too many people at this point who have not been personally affected by a COVID death. The case fatality rate is 1.7 to 1.8%. That means 18 of 1,000 people that get COVID, the original strain, will die. That makes it 17 to 18 times worse than seasonal influenza. The mortality rate for people over 85, especially institutionalized people, is 20%, 1 in 5. My first introduction to this illness was down in Luray, a nursing home that we were affiliated with. Well, we were affiliated, but we had the medical staff there was our medical staff. We got a phone call that they had 12 people with a fever, and by the time the dust settled, about 30% of their population had died. And in addition to death, I think it's important to remember that 1 in 5 people are suffering from symptoms more than 60 days after their diagnosis. This notion of long COVID with ongoing loss of smell, taste, cough, shortness of breath, ongoing symptoms continues to really be a challenge and something we're all still learning to understand. And then lastly, before I pivot into the vaccine, I started really reading more seriously in the last 2 or 3 weeks about the Delta variant. And one of the things I think that we've done well over the course of this year is presented a lot of the information without hyperbole and without always being grounded in the facts. And so I would encourage you all to do some reading about Delta and what you can find. There's some pretty good stuff out there. It's hard to encapsulate in a few words, but if I were going to do that, what got my attention was really the new British wave of infections. So as a case study, Great Britain has about 50 to 60% of their population vaccinated. So you would think that they're really not possibly going to have another big wave because so many people are vaccinated, especially so many at-risk people. but they have seen exponential growth, sort of straight line up growth in their number of cases in the last month. 99% of those cases are Delta. And Delta, by the way, is the same strain that caused the horrific outbreak in India over the last few months. So with 50% of the population protected, and the vaccines, as I'll tell you in a little bit, are holding against Delta, they are still seeing a significant spike in cases, almost all of which is Delta. The original Wuhan strain, the original COVID strain, had an R value of 2.7. That's a measure of how contagious something is. It means that on average, one person will give it to 2.7 other people. And that's in the absence of masking and other public health measures. They estimate that the R value of Delta is somewhere between 5 and 9. For context, the R value of smallpox was 8. So it's much more contagious. The viral shedding is much higher, and it seems like, and again, the data is all early. Delta's only been with us for a few months, but it seems like the mortality is higher as well. There's a study out of Ontario, Canada, that shows that the mortality rate is about 122% higher, so a little more than twice as bad. So Delta has our attention and creates even more urgency for us to get a vaccinated public. More broadly, the whole public, but certainly specifically to Valley Health, because we know that as we move into the flu season, we need to be able to provide safe care for our patients. Go ahead, Stan, you can go to the next slide. So I wanted to frame my comments today around our decision-making to move towards setting a policy at Valley Health that we need our team to be vaccinated, and where that comes from. And as I talk about this, and this is maybe more a style comment than it is a substance comment, it's been really important to our leadership that we talk about this from first principles. The why really, really matters. There's always going to be a pushback. We tell folks they have to do something, or at least that we require it for employment. And so we always want to start with why. And the why for us is really quite straightforward. Valley Health's mission is to serve the community by improving health. We love the fact that we're one of the larger employers in the community. We're proud of our team. We're proud of the workforce we have. But that's not our mission. Our mission isn't to employ. Our mission is to serve the community by improving health. And our operating principle is a journey to high reliability, which is a place where what should happen happens and what should not does not 100% of the time. And we talk and work a lot around high reliability. It is essential to us as we wake up and come to work every day that we are laser focused on the safety of our patients, the safety of our team, the safety of our community, and getting to the point, and it's a journey, where the things that are supposed to happen all the time, and the things that are not supposed to happen don't happen all the time. And infections, where people come to our facilities and get any infection at the hospital, and this is not unique to COVID, that's a never event. Those are things that should never happen. And they happen in all hospitals around the country. I'm not naive. But we have a tool, and looking at the vaccine, we felt that we have a tool at our disposal, which is our next best step, in addition to masking, in addition to distancing, our next best step to really reduce the chances that somebody can come into our building and get COVID. And the moral obligation there becomes a requirement. It's really A plus B equals C. We know we're here to serve the community. We believe deeply in the journey towards ensuring that people never get hurt in our facility, and therefore we must be vaccinated as a team. Harm prevention and community confidence are our highest priority. Wow, I typoed there, sorry about that. Next slide, yeah. So what are the kinds of things that we talked about in the journey we've been on over the last 6 to 8 weeks before our announcement earlier this week? Really putting a priority, and this is really more sort of practical primer for folks who are considering doing this in their own businesses. Education is really a priority. Boy, is there a lot of disinformation out there. I can't tell you the number of folks I've talked to and said some real things that I think of as really basic, but that people aren't hearing. The information bubbles are really hurting us here. I'll do one out loud, and I do a whole hour-long talk on this, so I'll spare you most of that. But the one we hear a lot of is this is an experimental, this is an experimental unapproved vaccine. I hear that all the time. And those words are well, one of those words is false and one is misleading. So the experiment around the COVID vaccine is over. The normal experiment, 3 phases to gain FDA authorization or approval, have all been done. We still study it because we study lots of things, but we study things that have been approved long ago. So there's no active experiment on the effectiveness or safety that will lead to approval. Those things are done. It's not experimental. It's true that it's not approved. That's a true statement. But in fact, it's authorized. And emergency use authorization is a parallel process that relies on the same sorts of clinical data for safety and effectiveness. So compare the language, and this is what we do a lot in our talks, compare the language between unapproved experimental and proven and authorized. And so we do a lot of talking about, hey, here's what the studies showed. Here's where the experiment ended. Here's what that experiment showed. And we're pretty careful about laying out the facts. Everything from the original studies to the New England Journal of Medicine published a series of 4,000 women who were vaccinated voluntarily during their pregnancy, and the outcomes were great. So trying to give people the idea that there really is good data out there if you go look for it. The second priority for us was having a respectful dialogue and accepting conflicting values. I really love to talk about this. For those of you that don't know me or my life story, my wife is an immigrant and was a political refugee when she came to America. And so we take really seriously in our family, talk about it all the time, that freedom is a blessing and that we enjoy the ability to make decisions for ourselves as a core value that we hold. We also understand that sometimes making those decisions has consequences. And so I am incredibly respectful of people who say, it is my autonomy, it is my privilege not to be vaccinated. And in the context of Valley Health, my response is absolutely. I get it 100%. Our priority is the safety of our patients. And if those two priorities come into conflict, we wish you nothing but the best. So it's not about I'm right and you're wrong. It's about we have different things that we value right now today. And we're really hopeful we can bring those two things into alignment. But if we can't, we wish you well and we respect your decision making. We've worked hard to create thoughtful and reasonable exception processes around religious and medical exemptions. Lost my slide there, see? There we go. One more.
Is that the one you want?
Nope, next one. Thank you.
All right. And we're just a little time short.
Oh, I'll speed up a little bit. I always get accused of talking too fast. So we've set up processes for managing exceptions and religious and medical, and I can talk about those at some level of detail, but there's law that dictates how you need to do the religious exemptions and the medical exemptions. We've put together a panel of experts that will work through those. Our communication strategy and our contingency planning, this is more business considerations probably than anything else, but again, the incredible importance of communicating clearly, effectively, providing everyone with the best information they need to make a decision and communicating very clearly about the process so there's not a lot of confusion. Any kind of decision like this leads to a lot of high-end motion, which is time for confusions. And then for us, contingency planning. We need to be ready for the fact that some folks may choose not to be in healthcare right now. And I don't think, by the way, this is just gonna be a Valley Health thing. I'm quite confident that at least all large healthcare systems will move in this direction in the next couple of months. So I think a decision to leave at this point because you really don't want to be vaccinated is a decision to leave healthcare. So I'll pause there. The only thing I would say, again, going back to where I started on the moral question is, I cannot contemplate the idea of today that I would be an executive or a leader in a long-term care facility and not mandate vaccines. I don't know how I would sleep at night.
Okay, and since we set up this panel discussion, Valley Health has actually announced its policy. Would you like to quickly reiterate that for us?
Yeah, sorry, I alluded to it, but I didn't realize you guys didn't know that. So yeah, earlier this week, Valley Health announced that by the time the late fall season rolls around in November with the increase in flu, et cetera, it is a requirement for employment at Valley Health to be vaccinated against COVID-19. And again, there'll be some exception processes that we'll work through for folks, but it'll be a requirement to continue to be employed at Valley Health that you be vaccinated.
Thank you, Dr. Feit. And just as a sidebar, on Monday, Virginia Hospital and Healthcare Association also came out with strong recommendations for vaccine requirements for healthcare system staffs. So now we'll move on to the Virginia legal perspective, and he has no slides. So I'm very pleased to reintroduce you to Robert Light, who always astonishes us with the things he's capable of offering wisdom on. Robert? You might have to unmute.
Can you hear me now?
Yes.
Okay. Sorry about that. I keep forgetting. I have a camera guard software on my computer and it always interferes with Zoom. So, okay. I'll try to do this quick. I think the first thing to begin, there's a lot of nuance in employment law, but I think ultimately we can begin with certain building blocks. And I think once you understand those building blocks, you can, the rest of it becomes comprehensible. First of all, I guess I would begin with Virginia is a right to work state. And by the way, folks, law is all about what ultimately, if there is a conflict between an entity like an employer or an individual, the question is who what can be done to have involuntary compliance, let's put it that way. So you have a right to work state, which is based in historically in the freedom of contract, which means that and also in the Civil War amendments of the Constitution, which says I am free to contract with you to offer my labor, and the employer is free to either contract with me to to accept my labor in return for compensation, or either party can part company if they feel like they can't work together. Right to work state basically means that there are very few guarantees to employment. It also means that unless you're a member of a protected class, or unless there is some other federal state statute, a employer is free to terminate your services for any reason, good, bad, or indifferent, again, subject to the idea that if you're a member of a protected class, or if your conduct or activity are expressly protected by statute. But those are exceptions, but they don't swallow the rule. The other thing that I will say is that along those lines is, well, let me go to that. So when we come to the idea, we breach the idea of a policy by an employer in Virginia, and again, CN slides have already talked about other states may have different, their state legislatures may have different policies. But in Virginia, to my knowledge, when it comes to vaccination, there have been no legislative or gubernatorial executive orders which would infringe on the ability of an employer to mandate as a policy that all of their employees be vaccinated. So you start with that. However, there are exceptions. The exceptions for the two biggest ones that I think you're going to see play out are the ones that were contained in the Valley Health press release, as I understand it, which is number one, health condition. And that would flow from the federal Americans with Disabilities Act. Basically, if you have a qualifying condition, which would be considered disability, your employer has to engage in a dialogue to see if a reasonable accommodation can be reached. I would caution, however, with any of these statutes, you have to be, and it's easy to forget because, again, using Valley Health as an example, they're such a large employer. Most employee protection statutes that exist, they're going to be subject to because their sheer size. They'll be under the jurisdiction of those acts. However, the coverage a lot of times depends on the size of the employer. So, for example, if you're a very small business, such as what I'm a member of, less than 15 employees, matter of fact, less than 10 in my case, those statutes that people assert in order to protect their right to do whatever, realize there may not be coverage for your particular employer. And I think that's important to remember is large employers have fair amount of, they have to undergo a great deal of regulation. Smaller businesses, not in many cases, not so much, unless there is a, and sometimes the state of Virginia in other cases does have catch-all for the smaller employers, and that's another topic. But just be aware of that. But the ADA, if the ADA engages again, but that's a dialogue for a reasonable accommodation. What it is not is a guarantee of a job necessarily, and it's not a exempt, and it's not a exemption, because there could come a point, depending on those are facts and circumstances sensitive. So even though everybody's negotiating, talking in good faith, there may come a point where a reasonable accommodation, is not possible, and therefore the employer and the employee must part company, or the employee will have to, in which to challenge it, they're going to have to seek redress in the courts if they think that the employer has not engaged in the kind of dialogue, or that there is in fact a reasonable accommodation. The other thing that's been alluded to in the materials is religious exemptions. I will hasten to point out that here you got to distinguish between large employers, state actors, and smaller businesses. Again, state actors, state actors always have to be concerned about the First Amendment to the Constitution, as far as religious matters. Larger employers, a lot of times, again, by federal or state law, have to take those into consideration. But when you get down to smaller employers, smaller private employers, first of all, the Constitution doesn't apply to them because they're a private actor. They're not part of the government. They're not acting under color of law. Secondly, to the extent that private actors by statute have been are required to take religious exemptions in consideration, you have to have enough employees to fall under those laws' jurisdiction. And if you work for a very small employer, that coverage simply may not be there. So again, you have to think about who's your employer, how large are they, and does their policy of a really small employer even have to take into consideration a religious exemption, for example, or not?
Robert?
Yes.
We're running really short on time now. So if I could get you to do a final summary, I would appreciate it. Sorry.
Oh, no problem. So basically, when it comes to employer mandates on vaccinations, I would say this: number one, generally speaking, in Virginia, they certainly can do it. There's no legal obstacle to it. Number two, like any general principle, there may be exceptions on a case-by-case basis. And again, the two big subject matters that you're probably going to see with COVID, with the COVID vaccines, are again, health conditions that may prevent someone from taking the vaccine, or certain faith-based objections. But number three is, if you work for a very small employer, even those exceptions, you need to check and consult with an attorney about whether those exceptions are even available in a very small in a small business context, because simply put, the employer may not be subject to their subject to the coverage of whatever state legal protections there are.
Great. Thanks so much, Attorney Light. And I'm afraid we've run a little short on time for questions and comments. Mary Jo, can we allow a couple of folks anyway?
We have 3 minutes left right now for our regular meeting, and I have to leave at 8. So I'm gonna have to say, please, can they refer questions to you by email? Or we can continue this discussion next week with you at Club Assembly. which is our next meeting next week. I don't have to announce that now.
Okay, well, that seems like an interesting and reasonable. Unfortunately, we may not have all of our panelists available at
We
that
won't,
time.
no, but I'm sorry. I'm sorry.
Okay, well, thank you so much, and thank you to our panelists. This
Thank you very, very much. Appreciate you being here. Okay, thanks very much again. We now need to do our Spirit Award. Oh, what am I doing? What's wrong? Oh, book. Oh, yes, book. Thank you. It's Not Fair. What an appropriate title. I mean, yes. It is by, I can't read this, Amy Kraus Rosenthal and Tom Lichtenheld book. And it is going to the Phoenix Project.
So just so you know, Dr.
What?
Fight, we don't give little doodads to people who speak. We donate a book in your honor to a local school or daycare center.
Yours
So
too, Cian.
It's Not Fair is your book. And Robert's too.
Yeah, and yours. Okay, Hal has spoken now. See, Anne? All right. I don't know why, I think you're fixing it every week here lately. Okay, till you like it. All right, 50-50, Gail. Why don't you have Robert over there draw it? And we do know that the 50-50 is over $1,000 right now, guys. That's not me. Oh my. 113,299. Oh, Peggy. Peggy is the winner of the card drawing. And Gail, Gail, how much did she get? 21.25. Okay. And she's drawing the card now. What was the card? 10 of diamonds. And how many cards are left, Gail? Gail? Wow, 9 cards. Okay, and for people at home, if you want, get a sponsor. Do it before the meeting or in the chat beforehand, because we're not going to be doing that run around like we did last year unless we have a really short meeting. Then we might. All right. Can I please get everybody to join me in the 4-way test of the things we think, say, or do? First is it true? Second, is it fair to all concerned? Third, does it build goodwill and better friendships? And fourth, will it be beneficial to all concerned? Thank you, everybody. Really appreciate you. Next week, Club Assembly, please be here. And I have to go. Bye-bye.
Excellent meeting. Thank you.
Thank you. I'm closing off early, guys. I'm sorry.
And so, Dr. Fight, just so you know, how many people did we have on site today?
I'm sorry. I have to leave
I got
because
that.
I have to get out here. I'm ending.
So,
Okay. I have to go to Baltimore.
so we had as many people live in the room as we did online, pretty much. So this was really worthwhile, and thank you so much.
Oh,
Great
definitely.
presentation. Thank you. Thank
Did
you
you
very
want-
much.
Very much so. Thank you. Informative.
Yes.
Thank
All
you,
right.
Ian.
I think the meeting's going to end now.
Oh, okay. Well, I don't know. Yes, I'm sorry. I have to go. Can somebody help Peggy with putting things away here today, guys? Okay, good. And I'll be here next week too. Can you, 1 minute? Yeah.